Good morning. Good morning, everybody. Good afternoon. Dear pharmacology community, college, students, and participants from literally all over the world. We have registration from the 5 continents. So on behalf of the IUPHAR clinical and translational section, we would like to extend a warm welcome to everybody attending Well Smart Medication Day 2026. This year event is being held under the theme The Influence of Race, Ethnicity, and Socioeconomic Factors on Clinical Pharmacology. My name is Maribel Lucena, and I am the chair of the Committee Medical and Clinical Pharmacology of IUPHAR. The aim of this IUPHAR initiative is to raise awareness of the safe and effective use of medicines, while also at the same time fostering international collaboration among students and particularly early career researchers. So I hope we can achieve these goals, and I wish you a very fruitful, informative, and inspiring webinar. First, we are going to introduce Professor Francesca Levi, who is president of IUPHAR, and who will address us with a welcome. We are very pleased to hear her introduction to this webinar.
Good morning. As a president of IUPHAR, I am very much welcoming you once more to the great initiative of our clinical section, that is to the Smart Medication Day. The theme of this year is race, ethnic, and socio-economic influences in clinical pharmacology. The topic is very important in our specialty and also in several aspects of life. Please learn and enjoy from the leading researchers and young scientists in this field, and enjoy our virtual meeting.
Thank you very much for this kind introduction. And we are both Professor Priya Galappatthy from the University of Colombo in Sri Lanka and myself from the University of Malaga, we have a great pleasure to conduct you and to welcome you to this webinar thematic learning section as we celebrate the 6th year of the Well Smart Medication Day. Let's make a brief history. Let's take a brief look to the history of this competition. And you can see here in this slide, the IUPHAR initiated this activity back in 2021 to align with WHO initiative, Medication Without Harm. And to foster a smarter use of medications and also the development of clinical pharmacology as a medical specialty in all countries. Over the last 5 years, we have explored a variety of cutting-edge topics, including clinical polypharmacy and chronicity, clinical pharmacology in the era of pandemics, pharmacogenomics and precision medicine, drug evaluation at the extremes of ages, and last year, sex-gender differences in clinical pharmacology. As you can see, the summary of these activities were published in British Journal Clinical Pharmacology and Pharmacological Research journals, and the link to access these publications you can find at the chat box in this Zoom video. And recording also of these webinars can be watched at the IUPHAR website. Also, during the Well Smart Medication Day webinar, presentations of the winner posters were made. This year outlined we will start with presentations from representatives of different committees and also presentations of the student poster prize awarded, and that will be presented at the three categories by students through general poster, research poster, and international collaboration posters. And there will be a closing remarks. And I think it's very relevant to emphasize that race and ethnicity encompass social, economic, and cultural factors that really makes a difference and influence outcomes. So therefore, highlighting these health disparities, their causes and consequences, also encouraging more inclusive recruitment, clinical trials, and reportings in the journal are essential for improving health outcomes and advancing equity in research and clinical practice. And therefore, to explore these topics, we will be joined by international experts who are representatives of various IUPHAR committees who have kindly agreed to participate in this webinar and help us shed light on these issues. All questions will be answered at the end of the session. However, you can submit your question to the Q&A forum during the presentations. Please write your name and institution. And without any further ado, I would like to present our first speaker, Professor Nicholas Buckley, who is Professor of Clinical Pharmacology at Sydney Pharmacy School, the University of Sydney, and is the chair of the Pharmacoepidemiology and Real-World Data Committee of IUPHAR. He will be addressing us on race versus ethnicity and socioeconomic issues.
Real-world data covers pharmacoepidemiology and pharmacovigilance, and race, ethnic, and socioeconomic influences are central to interpreting this data and also to making sure the benefits of studies in this area are shared. So this article is highlighting the concept of diversity and fairness in pharmacoepidemiology research and how all of these things should be considered, and also that there is diversity in the populations being studied. And it obviously covers many things here, but socioeconomic status and ethnicity are two of the key ones. And socioeconomics is pretty straightforward because everyone kind of agrees on what wealth is, and ethnicity is much trickier. Ethnicity is an entangled concept. Every country you go to, they would probably consider people who should be studied differently are different in every country. There's no shortage of research here. So if you do Google Scholar, you will find millions of articles where you look at socioeconomics and medication use, and millions of articles where you look at ethnicity and medication use. There's a whole journal devoted to this. I'm going to use two examples. This is from the Cancer Atlas, and so obviously this would be relevant to everyone studying cancer medicines in Australia. And it's just to indicate how important socioeconomic status is. So this is cancer diagnosis in Australia, and the lowest rates of cancer diagnosis are in these remote locations in the centre of Australia. They're there in blue. And when you look at socioeconomic status in the same sort of map, you see that these are also the most disadvantaged areas of Australia. So these have they're in the lowest decile of socioeconomic status. And when you look at cancer deaths, these are actually the areas with the highest rates of cancer deaths. So they've got the lowest rate of diagnosis, but the most deaths from cancer. So you can see if you were studying medicine use, that would be pretty important. And here's an example of that. Here's opioid medicines. You'd think that'd be being used for end-of-life care from cancer as its most important indication, but these are the areas with the lowest rates of opioid dispensing in Australia. Here's a worldwide example. So this is from Gapminder, a wonderful website. And this is showing lifespan versus income. And you can see there's a very strong relationship. Countries with higher income have higher lifespans, but that there is also quite a lot of diversity here. So you have maybe a 25-year difference between the highest and lowest for a given income. And a lot of this is likely to do with how well the wealth is shared. So there's Japan, Russia, not terribly different incomes, and 16-year difference in life expectancy. But let's not be too negative about this. Income is improving throughout the world, and so is life expectancy. So this is from 1950 through to 2023, and you can see that we've been moving up this trajectory. And so life expectancy is improving across much of the world, and so is income. And the two seem to remain closely linked. But when one starts to look at individual countries, we can see some countries are doing this much better than others. So there's Japan, used to have quite a poor life expectancy for its income, then became about average, and now is really one of the world leading places for life expectancy, and also has high income. And you could contrast that with the USA, which is really quite underperforming or only just average over that sort of time. So I'm going to wrap up there, but it's important if anyone's working in this area that they think about what's the best way to report on ethnicity and income and other issues that drive health equity. And here's a recent paper from in the BMJ kind of outlining best methods.
Thank you for this very interesting and provocative presentation. Thank you for the definitions, putting in context the scope of the problem and the final messages left to the audience.
Our next speaker is Professor Kazunao Kondo from Fujita Health University, Japan, representing the Japanese Society of Pharmacology. And he's talking to us on socioeconomic influences on clinical pharmacology, polypharmacy in Japan, particularly focusing on polypharmacy in Japan and influence of universal health insurance. Let's listen to Professor Kazunao Kondo. Thank you.
Hello, folks. My name is Professor Kondo, a member of Japanese Society of Pharmacology. Today, I would like to introduce the current situation of polypharmacy in Japan and the influence of health insurance system on it. Please check the indicated report published in 2024. This is one example which discusses the current situation of Japanese medication. The core data of this report says the median number of prescribed drugs was 7 in one local prefecture close to Tokyo, Ibaraki. The percentage of polypharmacy over 5 drugs was 74% of elder patients. This paper also says that the result included a certain ratio of PIMS, potentially inappropriate medications. For example, overprescription of proton pump inhibitor, diuretics, anti-inflammatories, and benzodiazepines tended to be prescribed frequently. One analysis for such situation is the effect of social welfare system. We have unique welfare system of universal health insurance. Well, this system has, yes, of course, both advantages and disadvantages. This system leads to fair chances to every citizen regardless of income. As you know, Japanese have gained the longest lifespan, and the social system may have contributed that. On the other hand, some people point out this system loaded heavy burden to national budget, and it is too generous for elder people. That is unfair. The self-payment of patients over 75 years old are limited just to 10% of treatment costs, and resting portion is covered by tax insurance. Similarly, elders between 71 and 75 are charged 20% of cost, but the younger generations under 70 have to pay 30% except infants. One aspect is that such condition may accelerate polypharmacy because elder people become easily access more medications for multiple disorders. Finally, I would also like to mention the possible solution for these inappropriate situations. One idea may be the reinforcement of education, specifically speaking, PSA, prescribing safety assessment, have potential for improving prescribing skills for younger clinicians.
We move on to our next speaker, Professor Nuala Helsby from the University of Auckland, New Zealand. She is a full professor of molecular medicine and pathology at the University of Auckland and specializing in transport and anti-cancer pharmaceuticals and drug treatments for autoimmune conditions. She was fellowship of the Pharmacology Society, following her role as an executive editor of the British Journal of Clinical Pharmacology. And she will talk on a very important issue, polymorphic and ethnicity factors which influence drug metabolism.
Drugs are eliminated from the body either by excretion or by a process called metabolism. Different individuals can have different drug metabolism status, which can influence the plasma concentrations achieved after a standard dose. So, for example, some people might eliminate the drug slowly from the body, and that can lead to excessively elevated drug concentrations, and potentially this poor metabolism can increase the risk of adverse events. In contrast, sometimes people rapidly eliminate the drug from the body by drug metabolism, and then that can lead to very low concentrations and potentially decrease the effectiveness of that medicine. There are many different enzymes involved in the biotransformation of drug molecules into pharmacologically inactive medicines, and regardless of which enzyme is involved, the drug metabolizing enzyme activity in our body is influenced by both genetic, inherited factors, and also by our environment. So let's first think a little bit about the genetics. Well, we've all inherited our poor metabolizer status from our parents, and that is because of something called genetic polymorphism, which is simply variation in the gene code between individuals. So remember, we get one copy of a gene from each parent, and we end up with a number of different possible inherited drug metabolizer traits in people. So for example, if a person's inherited 2 no-function genes, one from each parent, they will then have what's called a poor metabolizer trait. We also can have the opposite effect, where we can inherit increased function genes from our parents. And depending on the number of copies we've inherited, we can have either ultra-rapid metabolizer status or a rapid metabolizer status. Now, all of this is important on an individual level, but we also have to think about the inherited status that we all have from our ancestors. Because over many, many generations, we've ended up with a different prevalence of inherited drug metabolizer status across the different regions of the world. And one example of this is the enzyme CYP2C19, where inherited poor metabolizer status occurs in about 20% of people of East Asian ancestry and about 3% of people of Northern European ancestry. So this is all about our genetic differences, But what about environmental differences? So again, looking across the world, it's important to think about our ethnic differences, particularly the cultural differences in our diet, because we all eat different foods, we might use herbs and spices in different ways, and we drink different beverages. And these dietary differences can cause changes in drug metabolism because there are naturally occurring biochemical molecules that occur in certain foods. These are sometimes called polyphenols. And these molecules can either compete with the drugs for its metabolism or increase how efficiently the gene for that drug metabolizing enzyme is produced, and which is a process called induction. And two well-studied examples of this are the effect of grapefruit juice and the effect of vegetables like broccoli and cabbage, which are all known to alter the person's ability to metabolize drugs. But there's another ethnicity factor that we need to remember, and that's that we all have different cultural practices when it comes to the use of alternative medications, whether that's herbal medicines or traditional medicines. And one good example of this is the use of St. John's wort as a herbal medication, because these alternative medications have also been shown to alter the ability of a person to metabolize drugs. So the key thing to remember is that across the world there is a huge diversity in drug metabolism status in each individual person. And some of that is due to our inherited differences, and some of that is due to ethnic differences in our cultural environment. But this means that in each individual person, there may be very subtle differences in enzyme activity or very substantial differences. And sometimes these differences can influence the safety and effectiveness of medicines. Thank you.
Thank you, Professor Helsby, for making clear that ethnicity is not only genetics, but extrinsic factors play a key role.
Our next speaker is Professor Karel Allegaert, who is from the Erasmus University Rotterdam, Netherlands. He is representing the Paediatric Committee of the IUPHAR, and Professor Allegaert will be speaking to us on race, ethnic, and socioeconomic influences on clinical pharmacology, giving us a pediatric reflection. Let's listen to Professor Allegaert. Thank you.
As Paediatric Committee, we are more than happy to contribute to this World Smart Medication Day event. After all, at least 20% of humans are children, and the topics of this year's event are of obvious relevance for children as well. I'm Karel Allegaert, and this presentation has been co-created with colleagues Saskia de Wild and Katriona Wade. A lot of extrinsic and intrinsic factors can apply also to children when reflecting on, say, pharmacotherapy. And some are actually already present in the slide, like age and body weight. However, others need perhaps some conversion to pediatric meaningful aspects, like, for instance, puberty, or developmental pharmacogenetics, or ancestry. And furthermore, it's perhaps also useful to consider that smoking habits are not limited to first-hand smoking, but also secondary or third-hand smoking can have impact on pediatric health as well. And exactly the same relates to environment and, for instance, fine dust pollution. If we start with perinatal life, it's clearly shown that a clearly proven effective intervention in the first world does not necessarily translate in a similar effect in low and middle income settings. Antenatal corticosteroids turned out to be less effective in the ACT trial, illustrating the complexity of simply translating a practice within a given structure to another region of the world. And exactly the same has more recently been illustrated for therapeutic hypothermia, who also failed to confirm the effectiveness in the first world in low and middle income settings. If you subsequently shift to nutrition as one of the extrinsic factors, we already mentioned, obviously, that breastfeeding has variability in practices throughout the world, in part also driven by region-specific socioeconomics. This slide reports on the number of medicines assessed by FDA related to potential impact of obesity. In the long run, it turned out that 13 of the 97 labels were adapted for obesity, but in fact only in one of these labels there is information on children available. On the other side, related to undernutrition, it's already quite well known, as illustrated, for instance, by the Verelst review mentioned below, is that the pharmacokinetics will dramatically change when the child is in undernutrition state, related to both absorption, volume of distribution, as well as metabolism and elimination characteristics. It's important hereby to realize that children, because of their proportionally higher caloric needs, they are more sensitive to food shortages or disruptions. To shift to socioeconomic inequalities, we wanted to use the pediatric asthma as a well-known and described modulator of asthma control. And as you can see on this perhaps busy slide, but both this relates to management outcomes, but also in part related to maternal and child health outcomes and exposures that all co-affect the final poorer control. This is not only proven on a country and regional level, but even within cities. You can actually illustrate that underserved parts of the cities will also will be associated with poorer asthma outcome for children. Besides nutrition and other factors, we also wanted to highlight developmental pharmacokinetics as another example of one of these factors. They may be of relevance when considering safe pharmacotherapy in children. Obviously, similar to other populations, pharmacokinetics or pharmacogenetics can be instrumental to guide your practice. However, you have to hereby consider ancestry-dependent patterns, because some deficiencies listed over here are more prominent in some specific regions of the world. Think about glucose 6-phosphate and acetyltransferase deficiency, and all the other examples which are listed over here, are more prominent in given regions of the world, and therefore also resulting in potential more toxicity or in inadvertent events. Important also to integrate this in pediatric pharmacology is also aspects related to pharmacoepidemiology. And just as one illustration, aminoglycosides are relatively commonly used in newborns to treat suspected infections, but in the Asian population is a specific sensitivity to hearing loss. And the same you can use for carbamazepine and specific pediatric epileptic syndromes. So to wrap up, what we have tried to illustrate with the specific examples that yes, there's also ethnic and socioeconomic aspects related to pediatric pharmacology, and the art will be to have data, preferably from clinical trials or real-world data that are sufficiently inclusive so that we know the different covariates involved, and in this way can use available information to guide our practices in every individual child. And hereby would like to thank you for your attention.
Thank you very much, Professor Karel Allegaert. I think your topic that had been very well covered and your talk aligns with WHO initiative, Safe Care for Every Newborn and Child. Thank you very much. So we move on to our next speaker, who is Professor Sarah Hilmer. She is chair of the IUPHAR Geriatric Committee and head of the Department of Clinical Pharmacology and senior staff specialist in aged care, Royal North Shore Hospital, and professor of geriatric pharmacology at the Faculty of Medicine and Health in the University of Sydney. She will be addressing the topic race, ethnic and socioeconomic influences on aging, frailty, and medication use.
Hello, my name's Sarah Hilmer, and I am the chair of the Geriatric Committee of the Clinical and Translational section of the IUPHAR. For World Smart Medication Day today, I will talk on race, ethnic, and socioeconomic influences on aging, frailty, and medication use. Firstly, some epidemiology. The world's population is expected to age between 2020 and 2050. People aged over 60 years will double to reach 2.1 billion, and people aged over 80 years will triple to reach 426 million. Population aging started in high-income countries, but now lower middle-income countries are experiencing the greatest rate of change. By 2050, 2 in 3 of the world's population aged over 60 years will live in lower middle-income countries. It's important to distinguish between chronologic and biologic age. Chronologic age is the time since birth. Chronologic age, however, is only loosely associated with biologic age. Biologic aging results from the accumulation of molecular and cellular damage over time. Variability in biopsychosocial stresses and in susceptibility to them results in diversity in old age. Biologic age is affected by race, ethnic, and socioeconomic factors, including life transitions such as retirement, housing relocation, and the death of friends and partners. The impact of aging physiology on the pharmacokinetics and pharmacodynamics of medications varies with the person's biological, not their chronological age. Now we think about race and ethnicity and biologic age. The prevalence of racial and ethnic diversity amongst older adults differs internationally, with migration patterns over time. Race and ethnicity affect susceptibility to and lifestyle factors associated with biologic aging. When we think about socioeconomics, there's a consistent association between socioeconomic deprivation and more rapid biologic aging. And it's important to remember that race, ethnicity, and socioeconomic factors impact throughout life, from development through adulthood and old age, on both intrinsic and extrinsic factors that affect healthy aging. Socioeconomics also influence frailty. Frailty is multi-system physiological dysregulation that results in increased vulnerability. It's closely associated with advanced biologic age. This study from the English Longitudinal Study of Aging cohort is one of many international studies that have examined this. Here you can see that when you look at people aged 50 and look at how much time they have left, how many years they have frailty-free in yellow and years with frailty in blue, those who are most wealthy, who are least deprived, who have the most education, and who are married, have more time living frailty-free and less time living with frailty. Race, ethnic, and socioeconomic factors are also associated with potentially inappropriate medication use in older adults. This includes overtreatment with unnecessary or harmful medications and undertreatment with medications that may benefit the older person. Now, why is this so? No one knows, but here are some ideas. Firstly, people who have socioeconomic deprivation often have increased multimorbidity and polypharmacy in old age, which of course would increase your risk of having a potentially inappropriate medication. Secondly, this may relate to issues around access to healthcare, such as specialists to guide complex prescribing and medication reviews. There are often issues around medication costs and differences in health literacy and beliefs about medicines and beliefs about aging that can impact on the appropriateness of medication use. Race, ethnic, and socioeconomic factors are also relevant to medication use for age-related diseases. And here's an example of treatment of dementia. It's an Australian study of all people aged over 65 years with dementia in 2021. Here you can see that the factors associated with the use of anti-dementia drugs, such as cholinesterase inhibitors and memantine in people living with dementia, included socioeconomic status, whereby those with the most disadvantage in quartile 1 had less treatment with anti-dementia drugs. However, those with the most advantage in socioeconomic status had the least treatment with additional psychotropics. So in conclusion, there is a complex intersection of race, ethnic, and socioeconomic factors with biological aging, frailty, and medication use. And these are important factors to consider when prescribing for older people. Thank you.
Thank you very much, Professor Hilmer. And I think that you have focused in a very interesting and relevant issue, which is put the growing number of older people in low and middle income countries into context.
Yes, thank you very much, Professor Sarah Hilmer, I think, and also highlighting how socioeconomic factors affect the biological age and how it affects the dosing and clinical pharmacology. Our next speaker is is the president of IUPHAR, Professor Francesca Levi-Schaffer, and she's from the Institute of Drug Research, School of Pharmacy, Faculty of Medicine, the Hebrew University of Jerusalem, Israel. And as I mentioned, she's the president of IUPHAR, and she's going to speak to us on immunopharmacology, variability in immune response with race, ethnicity, and access to high-cost drugs. Over to you, Professor Francesca.
My short talk will be on race and ethnicity as their effects on PK/PD and the access to high-cost drugs. How much PK/PD really varies by race and ethnicity? Across 620 FDA NME, only 6% reported any racial ethnic differences in PK, safety, or efficacy, and only 0.16%, that is one drug, required a race-specific starting dose change in labeling. Indeed, the proportion of papers claiming ethnic differences is decreasing over time. When differences exist, they usually involve biological mediated processes, first-pass metabolism, protein binding, hepatic metabolism, renal secretion, or polymorphism in CYP and transporters. Many determinants of variabilities, diet, weight, age, comorbidities, concurrent drugs, enzyme transporter expressions, are individual and not ethnic, and we must now focus on inter-individual variability rather than race categories. Moreover, increasing numbers of clinical trials are carried out as multi-regional and diverse enrollment is minded to detect clinical relevant subgroup effects. We must therefore emphasize that race has no solid biological basis. How access to expensive drugs varies and matters for outcomes, while PK/PD difference by race ethnicity are usually modest differences, in access to high-cost drugs are profound and clinically important. Most new drugs are high cost. Cost is associated with up to 75% abandonment for some specialty drugs. So we have higher discontinuation, lower initiation, treatment delays, lower drug utilization, and low-income patients often find drugs unaffordable. Consequently, unequal access to costly drugs generated and is a consequence of geographic and socioeconomic disparities. In conclusion, most drugs do not need race-based dosing. When they do, it is usually for well-defined mechanistic reasons that we all know: polymorphic metabolism, low variability, narrow therapeutic index, etc. Race is a poor proxy for biology, but a strong proxy for exposure to structural barriers, cost, insurance, design, geography, that drive who receive high-cost therapies. What is the perspective for pharmacology? The design development programs around diverse clinical populations, together with mechanistic PK, PD, and pharmacogenomics. In implementation, cost and coverage matter more than small PK/PD differences. Supportive value-based pricing, lower patient cost sharing, and better price transparency is crucial to making precision therapeutic equally useful. Thank you.
Professor Levy. And she has also highlighted an important message that is going to be repeated along this webinar, that race has no solid biological basis, and the reference to the access to new drugs that are very, very expensive. So let's move on to our next speaker, Dr. Jennifer Koenig, in the School of Medicine at the University of Nottingham, based in the Derby Medical School, and she has been very much devoted to pedagogical approaches in bioscience and work on many projects in science communication. So she will address an outstanding topic in which she is much involved, such as addressing ethnicity in teaching interindividual variations in pharmacogenetics.
Hello, my name is Dr. Jenny Koenig, and I'm really pleased to be able to share some of the work that we've been doing about teaching about ethnicity in the context of pharmacokinetics. So the first question is, what should we teach? So we did a scoping review, which was published back in 2021. And 3 key points from this were that over 2/3 of the papers showed no difference between ethnic groups. There were lots of different mechanisms reported that are responsible for generally inter-individual variation between humans. This included genetic variation, but also diet, environment, lifestyle, and so on. But what was notable was that the language in these papers really referred to ethnicity in terms of white, black, Asian, African. You might think of these as the sort of continental scale racial groupings. Then the next question was, how should we teach? This is where we took lessons from genomics education research. And this points out this idea of genetic essentialism, which is the mistaken belief that same-race individuals are genetically homogeneous, and that most racial differences are therefore determined by genes, which is clearly wrong. Furthermore, Brian Donovan's group showed that students who learn about racial differences in the prevalence of disease are more likely to agree with a genetic argument for racial inequality. But the good news is that better genomics education can reduce racism, and therefore that's an important message for pharmacogenomics educators to take away. So therefore in this paper what we wanted to know was how our students understand ethnicity and what effect our teaching has on this. The study methodology included pre- and post questionnaires either side of our scheduled examinable teaching, and then a few weeks later followed by some focus groups to get in some of the more nuanced ideas. And this had ethical approval. So the answer to how our students understand ethnicity is that there are very many different ways that students can think about this. The most common response was words relating to culture, traditions, and so on, followed by place of origin, geography, nationality, and then other contributions from genetics, ancestry, race, and appearance. And many students gave answers that included many of these different categories. So this is really in contrast to the way ethnicity is framed in the pharmacokinetics literature, which is more about the sort of continental scale racial groupings of white, black, and so on. We asked a number of questions, but one example to try and get at how they think about ethnicity in pharmacokinetics asked the question, study has shown some ethnic groups differ in the rate at which they metabolize a drug. Which of the following mechanisms do you think might underlie this difference? And the largest response was mostly genetic, followed by both genetic and environmental. But after the teaching, there was a significant shift away from the mostly genetic response towards more recognition of what we called environmental or non-genetic factors. So clearly, the way we were presenting our teaching was having a good effect. The focus groups were really fascinating. I think what surprised me was that a lot of students didn't really know what to think because they had no previous teaching about ethnicity and genetic variation. Some did recognize a previous misconception, so previously thinking that everything's mainly down to genetics, but now being able to see the influence of environmental factors. So I think that was a message for our overall curriculum, that we needed to include teaching around ethnicity and genetics and talk about environmental factors as well as genetic mechanisms. So that's just a taster of some of the findings from that paper. It was a fascinating study to carry out, and the references there is published last year. Thank you very much.
Thank you, Professor. Kenny. I think it's a very, very interesting and provocative talk that we can comment further during the discussion. You mute, Priya, you are mute.
Sorry, yes. So it's very interesting to see how the responses of students on race, ethnicity, and impact on pharmacogenomics. The next speaker is Dr. Pravin Prasad from Maharajaganj Medical Campus in Tribhuvan University, Nepal. And he is representing the Early Career Researcher section of IUPHAR. And Dr. Prasad is going to speak to us on health insurance and clinical pharmacology, particularly in reference to Nepali situation. Thank you. Over to you, Dr. Prasad.
Welcome, everybody. Hi, this is me, Dr. Pravin Prasad from Nepal, welcoming you from a small speech regarding health insurance and clinical pharmacology to reflect the theme race, ethnicity, and socioeconomic influence in clinical pharmacology for this WSMD 2026. When we see the global pattern of medicine use, we see that the medicine use pattern has been increasing. However, the problem of inequity is still persistent. One of the reasons for this would be insurance coverages. We see that reimbursement decisions are directly influencing the prescribing practices in some part of the globe. In other part, when the insurance status is not active, there is a problem with the medication access as well as adherence. Study the impact of health insurance on drug development. It is seen that the countries which has a very good health insurance coverage has a very positive pharmaceutical innovation uptake. However, in countries where the health insurance coverage is very poor, as for example in the low middle income countries, the number of study being conducted is also very less. Around 4% of clinical trial globally is being conducted in LMICs. Because of this, the data being generated from the LMICs are also limited. Even if a country has a very good insurance policy, the insurance design itself could lead to some social inequalities. Patients with limited health insurance would face several problems like formal restrictions, prior authorization delays, and higher cost sharing for essential medicines. From pharmacological outcome, this could lead to subtherapeutic dosing, treatment discontinuation, and preventable drug-related morbidities. The set of problems in areas with poor health insurance coverage, as per LMICs, would be quite different, which would include increased risk of counterfeit medicines, irrational polypharmacy, and early discontinuation of the treatment. With this knowledge, I would like to just give a brief overview of Nepal's experience in health insurance. It was started around 10 years back, had some green flags as shown in the slide. Amid the green flags that we have for our Nepal health insurance policies, we do have some red flags in terms of coverage, equity, and financial protection. Because of all these red flags, what we can conclude is that population-specific pharmacology for Nepalese patients remain largely inaccessible. So it can be considered a privilege still for major part of the country. So with this, I would like to end my presentation today. And if there are any queries, please feel free to contact me. Thank you.
You, Professor, Dr. Pravin Prasad. You are the first time that early career researchers participate in this webinar. You are very, very welcomed. And I just want to highlight how well Nepal as a country has done in the selection of posters, as we will see. And your presentation has been very interesting, and we will have time in the discussion to make some comments. So we open the discussion section, Priya.
Yes. So now we get on to the discussion section. If you have any questions, any attendees, if you have any questions, please post through the Q&A and we will take those questions. We are told that as of now, there are no questions posted there. So let me, in that case, pose a question to our panelists. I think the President IUPHAR posted a very strong argument that there is no strong, solid biological basis for race in clinical pharmacology, and it is rather that it is related to inter-individual variation. So I think probably during this discussion forum, we can ask for the comments of other panelists on this proposition made by Professor Francesca Levi-Schaffer on race and ethnic influences in clinical pharmacology. So who would like to go and give your comments on this? Any of the panelists can take it up, please.
Can I add
Yes.
something? We study asthma, and I can see that the real difference is in the inter-individual difference. So we go to personalized medicine. The issue is very important to find out the differences you have in definition of the disease. And then also, based on that, we will give the different drug, and people will, of course, respond differently. Another thing I wanted to say, I was the chair of the Immunopharmacology Committee, and especially in our field, immunopharmacology, you see how the cost of the new drugs is tremendously high. And because they are mostly monoclonal antibodies. And the cost, as I pointed out also in my short presentation, but all the panelists touched this topic, is the one involved in the different treatment of different populations, not based on race, not based on ethnicity, but based on how their access is to high cost drugs. Sorry, but I thought it was important to point out.
Yes.
Yes, thank you very
Thank
much for that, for the explanation, Professor Francesca. Yes, Nuala, you have your hand raised. Yes, what are your comments on that topic? Yes.
I would totally agree with Francesca, and I think Jennifer's talk also quite highlighted the importance of basically thinking about an individual, because it's about both the intrinsic factors, your inheritance, and your environment, your cultural environment. Everything is all packaged together. So we should always be thinking about the individual when it comes down to the medication safety and effectiveness for each individual, not based on a population descriptor, as was raised earlier.
Yes, thank you very much. Yes, I think your presentation also highlighted the same fact. This, yes, I think we have got some interesting questions. So first, yes,
I would like to add to this line of discussion the Jennifer's presentation that she made a very, very strong point avoiding student misconceptions regarding ethnicity and genetic similarity. But when it comes to the educational intervention, however, had little impact on students' views about possible underlying mechanisms for ethnic differences, let's say, in hypertension. What do you think this happened, and how could this concept be changed effectively?
Thank you. Yes. I think I think the answer to that is that we grow up with ethnicity and race all around us from birth. And the way, I think from talking with lots and lots of students and colleagues, the way we understand ethnicity is influenced by so many different things that one single intervention on, in my particular case, pharmacokinetics, is not going to change that person's whole view of ethnicity. So we asked about hypertension. In the UK, we have racial prescribing. So you get a different drug if you're of Black African origin compared to anybody else. So they didn't, our teaching on pharmacokinetics, they didn't transfer that into hypertension. And the subsequent conversations we've had across the whole of our curriculum is basically saying that we need to reinforce very strongly this idea that we need to counteract this misconception that all African people are genetically homogeneous and all Asian people are genetically homogeneous. We need to really work hard, very, very hard, because all the time around you, you're seeing things that are suggesting that's true when it's not. And the President of the United States going out and making statements that people will listen to and they will absorb all of those different statements. It's incredibly difficult to change that viewpoint. And I think the way we talk, there's one question in the chat about the way we talk about race helps to reinforce this misconception. So if pharmacologists continue to talk about African and Asian, reinforcing this misconception that there's something biologically different about Asians. But we're lumping together Pakistan with Japan in Asia. That makes no sense.
Yeah.
Pakistan is more, so where does Turkey and Iraq fit in? They don't seem to fit in anywhere. So it it seems like a long hangover from the past, which doesn't have a clean scientific definition, that's not used in a scientifically rigorous way. Sorry, I could talk a long time.
Yeah,
That-
but the message is we need more medical training, perhaps, in race and ethnicity, no?
Exactly,
Yes.
a rounded education.
Issue. Yes.
And in fact, there's a very interesting comment that I believe Alexandro McGill has said, I believe that we should stop the use of the term race for the humans. What do the panelists believe? And I see Francesca has answered, I agree. So I think so that this point has been highlighted during this webinar. There are some more questions. Yes, Maribel. Yeah.
Yes, I think I would like to also make a question, to ask a question to Pravin, because he has also pointed out, similarly to Francesca, how health insurance has also been covered by Professor Kondo, how health insurance in a country can impact on the development of drug research in general, but particularly on clinical trials. You have made some point of that, but if you could expand on this point, Pravin.
Thank you, Professor Isabel. Am I audible?
Yes.
Yes.
Okay. So, when I was preparing my presentation, we had a discussion with our team. We had a clinical trial going on in our institute. So, what we agreed was when we have a very good health insurance policy or health system, so we have a very strong patient base. So, people they start trusting your institute, they start visiting you frequently, and they start to trust the physicians there. So with this, it is very easy to roll out any clinical trials that we have that we have an opportunity. So in general, if we have a health insurance that is not just specific for clinical trial, that is going to uh, help build what should I say, trust with the patient. Then another thing, when we have some vaccine trials going on for pediatric group. So even in those population also, uh, when we have this insurance, then the parents, they are very much confident on the vaccines. So it's very easy for them to accept the interventions that we are planning. And again, it is a requirement by the regulatory also, so it has to be done. But on the contrary, we have very few companies within our country that are rolling out insurance for the clinical trials. There's an issue with the accessibility. And again, whenever we have a insurance policy for the clinical trial, the problem is that they are only going to reimburse whatever is related to the interventional product IP and not for the other things. So yes, we have some limitations with the insurance policies that are available in Nepal, but the communication is the key strategy. And when we communicate the limitations of the existing health insurance policies for the clinical trial, that would help in building up a sound, a good, a safe environment for conducting and continuing clinical trials in Nepal. Having said this, again, having a national health insurance policy with a very good coverage will help build trust in the community and will help in the rolling out the clinical trials within the country. I hope I answered your question.
Thank you, Pravin. Yes. Yes. I think that the update and the previous what is the academic ethical now I can recall the name. It states very clearly that all patients included in a clinical trial should receive the medication free. They do not have to get to pay for the medication. So that it's a very important point that should be indeed sometimes could encourage the inclusion in a clinical trial. If you allow me, Priya, having the advantage of having Professor Karel Allegaert with us and also Sarah Hilmer at the extremes of ages, pediatric and geriatric, he has pointed out something that I really think is very important, says that the effectiveness of different strategies that are working very much in countries where these drugs have been developed may not necessarily translate into other scenarios. And I don't know if you could expand a little bit on this point.
Well, well, at least these observations are hypothesis generating, and I think we still have to use the framework of intrinsic versus extrinsic factors. And so, why does prenatal steroids for lung maturation have a completely different outcome in a completely different setting compared to the high income countries, and same holds true for therapeutic hypothermia is poorly understood until now, but it's assumption that has to do with different disease mechanisms like um, inflammatory aspects, like aspects related to maternal care, maternal diseases, whatever. So I consider this within the same framework of intrinsic and extrinsic factors, and rather very interesting observations and rather hypothesis generating, because if we understand the differences, we can take perhaps a more effective treatment. And I'm best familiar with perinatal care. We shouldn't forget that actually also and middle income countries have learned also the quote unquote rich world, very strong improved outcomes, like but that's not related to pharmacotherapy, but rather related to family integration, knit cap and other type of things. These have been invented in low and middle income countries and subsequently has been translated so it's a bidirectional communication, and not only simply extrapolating. But that would be my two takeaway messages. One, it's at least hypothesis in generating, applying the framework of intrinsic versus extrinsic. And secondly, we can learn from each other in either direction.
Yes. Thank you. Thank you very much. Priya, I think we are behind time.
Exactly. I think that's what I was going to say. I think we have exhausted the time that we have for the Q&A session. But any questions, the panelists will be happy to answer. I see there are many questions which the panelists have already answered through the Q&A forum. So please continue to do that. I think we will now move on to the next very important section, which is announcement of our winners. So first one will be on announcement of the general poster winners, which will be announced by Dr. Saibal Das from India, who is representing the Medical and Clinical Pharmacology Committee. Over to you, Saibal, to announce the winners.
Thank you, Professor Priya. So it is my pleasure to announce the general poster finalists and the prize winners for this year's event. And this initiative was actively supported by the active participation of several engaged professional societies, and we sincerely acknowledge all the participating societies for their contribution, support, and encouragement, particularly in promoting the young researchers. So we now recognize the 2026 general poster finalist, who represents an international group of researchers from Brazil, China, Indonesia, Spain, Romania, Italy, and Sri Lanka. So that we are displaying here the 2026 general poster finalists, and we have multiple representations and from different countries, and these are the posters which are being shown here from Romania, Andrea, then from Sicilia, from Davin, and from countries from Indonesia, and from this we are showing this from the Spain, and the sex and BMI differences, and this is the these are the other posters. So if we can move to the next one. Yes, so this is the one of the finalist poster, and now we come to the winning posters, and who are the general poster winners, and the second position is awarded jointly to two groups. The first one here who has won the second position is from Mexico. Ricardo, Stefania, and Gabriel have showed and presented their poster on the title, Same Treatment, Same Response.
Same treatment, same response. Have you ever heard this phrase before? The idea of giving everyone the exact same treatment is a dangerous misconception that can alter the course of the disease someone will have, since not everyone responds the same to a certain drug. Good day, we are Ricardo, Stefania, and Gabriel, medical students at Tecnológico de Monterrey. So what are the factors that influence this pharmacological response? Well, how that both race and ethnicity are a good starting point, since they greatly correlate with pharmacogenomics, but we have to remember that they are social constructs and require self-identification.
What is pharmacogenomics? Pharmacogenomics studies how genetic differences between populations affect the way people respond to medications. Because of this variability, the same treatment may not produce the same result in every patient. However, many official medical guidelines are mainly based on American or European populations, which can make them less inclusive for other ethnic or socioeconomic groups. Furthermore, socioeconomic status also plays a major role, since factors like medication cost, transportation, and limited healthcare access can reduce treatment adherence and even participation in clinical studies. What can be done to improve medication access? Expanding access to medicines can be achieved through economic and policy strategies, where healthcare systems should promote more diverse clinical trials, personalized medicine, promotion of generic drugs, and equal access to healthcare resources.
This comic illustrates our central message, using asthma as a clinical example. We present two patients from different backgrounds with similar symptoms who receive the same treatment, yet the responses differ. This shows that drug response is not determined by the disease alone. Part of this variation is explained by genetic differences, such as polymorphisms in the ADRB2 gene. Drug response is also shaped by environmental, social, and medication-related factors, including adherence and gaps in healthcare communication. Together, these elements show that similar patients can experience different outcomes. We would like to thank Dr. Jose Hernandez for his guidance and support. Thank you.
Yes, so we now move to the second joint holder of the poster winner, and the title is Global Data, Local Bodies, and the group is from the University of Malaga, Spain. Let us hear from them.
Hello, we are Carlos, Esteban, and Andy, and first of all, we would like to thank the acknowledgement our poster, Global Data Local Bodies, has gotten from both the IUPHAR and the Spanish Society of Clinical Pharmacology.
This poster addresses how AI models used for clinical decision-making can lead to problematic results when used on certain minorities due to them being trained with unrepresentative data.
We select this topic because it's innovative, highly relevant, and global nature, given that AI currently represents both the present and the future of medicine worldwide.
AI can easily process years of medical research. AI is used to identify therapeutic targets using genomic data, to repurpose drugs, to optimize clinical trials, or to monitor adverse effects. However, these models are trained on predominantly Caucasian and high-income populations.
To present this information as visual as possible, we created a comic where AI is the main character. As it steps into the medical world and interacts with patients from different races and ethnicities, it starts to realize that its data isn't entirely accurate. The character's journey captures the evolution that artificial intelligence needs to go through in medicine and pharmacology, so that it can become a truly effective global tool.
The aim of our project is to raise awareness of this issue in order to ensure the best treatment to all patients. And we also hope that in the process, we help you learn a bit more about AI medicine.
That's great. Now we come to the general poster champion, and the first prize winner for the 2026 poster is Sujal Padil from Maharajganj Medical Campus in Nepal. And we warmly congratulate Sujal for his achievement. Let us hear from Sujal, and the title is Poverty, the Invisible Comorbidity.
Namaste. My name is Sujal Paudel, and I'm speaking to you today from the field posting in a remote region of Western Nepal. The title of my poster is Poverty, the Invisible Comorbidity. Let's get into the core argument. In pharmacology, we adjust for renal and hepatic failure because they alter drug response. Poverty does the same, yet it is rarely accounted for. When a patient has no food, no money, and no rest, we still prescribe as if nothing has changed, and when treatment fails, we label them non-compliant. Actually, it is not the patient failing the treatment. It is our system failing to see the patient's reality. And in statistics, this reality is vast. In developing countries, 1 in 10 medicines is substandard or falsified. Right here in Nepal, nearly a quarter of the population lives below the poverty line, over 1/3 of the children are stunted, and more than 60% of health expenses are paid out of pocket. This chart displays how poverty distorts drug action across ADME through 3 main pathways. First, malnutrition. Hypoalbuminemia increases free drug fraction, making standard doses toxic. Altered enzyme activity, cord atrophy, and reduced GFR impairs ADME. Second, cost-driven behaviors like pill splitting and incomplete courses create fluctuating plasma levels and therapeutic failure. Third, drug quality. Reliance on substandard or falsified medicine leads to subtherapeutic exposure and unpredictable response. These mechanisms translate into treatment failure, antimicrobial resistance, drug toxicity, hospitalization, and increased mortality. This creates a vicious cycle. Failed treatment drives financial strain, which further worsens adherence and outcomes, deepening poverty itself. So what can we do as a clinician? We must screen socioeconomic status routinely, adopt poverty-adjusted prescribing, favoring cost-effective, quality-assured generics, and strengthen surveillance against substandard medicines. To conclude, poverty is not just a socioeconomic factor, it's an active pharmacokinetic variable that silently redirects outcomes. And as a clinician, it is our responsibility to respond and to make this invisible comorbidity visible in every patient and in every prescription. Thank you.
Thanks. We again warmly congratulate and thanks to all the finalists, winners, participating societies, and the evaluators for your active contribution. Thank you so much.
Thank you, Dr. Saibal, for this kind presentation. Now we move on to research poster winners that will be announced by Professor Gordana Dragovic, Lukic from Serbia. She's a member, counselor of the Medical and Clinical Pharmacology Committee, and also Professor of Medicine at the Department of Pharmacology, Clinical Pharmacology and Toxicology, Faculty of Medicine, University of Belgrade, Serbia. Gordana, you have the word.
Thank you, Maribel, for the kind invitation. It's my great honor to be with all of you together today. Today is a World Smart Education Day, and for me, it's a privilege to announce the research posters finalists. But before I go on and move, I would like to say that these posters, which I'm going to present, are submitted by the pre- and postgraduate students and present original research related to the sex-gender differences in the clinical pharmacology. So in this session there were a total of 6 posters in the final competitions, of which 2 were selected as winners. So you might see I just need to kindly ask to go back, to see the posters which were submitted from the Indonesian Pharmacological Society, the one on the left-hand side, and on the right-hand side, the poster is coming from the Nepal and the Society of Pharmacologists of Nepal. Next, please. Then we also received the posters from the Chinese Pharmacological Society, the one on my left-hand side, and on the right-hand side there is a one from Murcia, España, and now it will be my great pleasure to announce the 2 winners. This is the second winner, the second place winner, and now this is Jean-Paul Nebot coming from the Iași and the University of Medicine and Pharmacy in Romania, and I would like us to hear his presentation.
Equal doses do not guarantee equal effects. For millions of patients, pollution and diet silently change how drugs work, and in this presentation, we will explore just that. Polycyclic aromatic hydrocarbons are primarily generated through the incomplete combustion of organic materials, such as fuels and biomass, and they're absolutely everywhere. They're in the air, in the water, in the soil, and even in our food. Their lipophilic characteristics are what aid them in achieving essential systemic concentrations, and in order for them to be eliminated, they are metabolized by the cytochrome P450 enzymes like 1A1, 1A2, 1B1, and 3A4, and they induce them through the aryl hydrocarbon receptor pathway. Now, what we found is that chronically exposed individuals show high concentrations of urinary 1-hydroxypyrimine, a metabolite of these compounds associated with pro-inflammatory cytokines and biomarkers of oxidative damage. Now, why is that important? Because it leads to chronic systemic inflammation, which many studies showed that through pro-inflammatory cytokines, it paradoxically downregulates the cytochrome P450 enzyme complex via lower mRNA expression. In turn, downregulating these enzymes will result in reduced drug clearance, increased toxicity through high systemic drug levels, or diminished therapeutic efficacy through lower drug activation in some cases. As we all know, these enzymes are responsible for the metabolism of a significant number of drugs with vast clinical utilities. Wonderful. Now that we understand the integrated mechanism, let us move on to why it is relevant to us. From our findings, low-income groups from the United States, from Central and Eastern Africa, all the way to Southwestern and Southeastern Asia are chronically exposed to high PM2.5 levels, not only because of environmental factors, but also through occupational and residential factors. So, how can we protect ourselves from these compounds? We found that fruits and vegetables, especially those rich in pigments acting as antioxidants, help mediate the oxidative stress and inflammation caused by exposure to polycyclic aromatic hydrocarbons, which is great news, only to find that globally 33% of countries lack fruit and vegetable availability to meet the recommended intake, and that in 2021, fruit and vegetable intake accounted only for 34.4% and 62.7% of optimal levels. Moreover, the cost of a balanced fruit and vegetable diet exceeds affordability for approximately 1.58 billion people, especially in Africa and in Asia, despite implemented programs. In the end, what we should focus on really is improving access to antioxidant-rich diets, considering antioxidant supplementation, adjusting drug dosage, and of course, deepen the understanding of these effects through research. If we ignore environmental and dietary factors, we risk prescribing the right drug at the wrong dose. Thank you.
This was really wonderful, and thank you for your tutor as well. Now we move on, and really great pleasure is to announce the first winner. So, if I may just say that this poster is entitled Genetic Diversity, Drug Response, Ethnicity Data Gaps in Pharmacovigilance, coming from the Brazilian Society of Pharmacology and Experimental Pharmacology. Baggio and the authors are the first place winners, and I would like us to hear the presentation, please.
Good afternoon. My name is Darciane Baggio from the Federal University of Paraná, Brazil. I am pleased to present a work entitled Genetic Diversity, Drug Response, and Ethnicity Data Gaps in Pharmacovigilance System. Drug response variability is influenced by several factors, including genetic, ethnicity, and ancestry. Indeed, pharmacogenetic polymorphisms can directly affect drug metabolism, therapeutic response, and the risk of adverse drug reaction. For example, HLA variants are associated with severe cutaneous reaction to carbamazepine. CYP2C19 variants can reduce the antibody response to clopidogrel, and CYP2D6 variability can influence the risk of opioid toxicity with codeine. These examples shows why population diversity matters for drug safety. However, international pharmacovigilance database differ in how demographic and ethnicity-related variables are available. In Brazil, although VGMed is used for diverse drug reaction reporting, ethnicity-related data are not publicly available. To illustrate this, we analyze notifications related to the three examples mentioned earlier. As shows the figure, the data describe a diverse event, year of notification, age group, and sex. However, there is no available information on ethnic and ancestry variability. This creates an important data gap. Brazil is one of the most genetically diverse populations in the world, but without transparent ethnicity or ancestry-related variables, it becomes more difficult to identify population-specific safety signs, evaluate pharmacogenetic disparity, and advance in precision pharmacology. Therefore, our key message is that genetic diversity shapes drug response and drug safety. Improving demographic transparency in pharmacovigilance system is essential to detect population-specific risks and to support more equitable and safer precision pharmacology. Thank you very much.
You. And I suppose that we are moving on.
Thank you very much, Gordana, for introducing the poster winners. Now we move on to the International Collaborative Poster winner announcement. It will be announced by Professor Gabriele Stocco of Italy, again representing the Medical and Clinical Pharmacology Committee. Over to you, Gabriele, to announce the winners.
Hi, in this section, we prize the International Collaboration Poster winners. It is my great honor and pleasure to announce these excellent posters. This poster highlight diverse approaches to pressing global health challenges. In particular, they showcase innovative research spanning early heart attack diagnostics, cross-border self-medication practices, and health equity in precision pharmacogenomics. So there were 3 posters in this category. Hopefully next year we will have more, but still they were great posters. So this is one that was presented, but was not awarded. I'm sorry about that, but it's still interesting on health equity in precision pharmacogenomics. It comes from Dr. Guan from Guangzhou Medical University in China. And then we have the 2 winners. One is a collaborative study from Romania and Italy. And this award-winning poster presents a meta-analysis on circulating BIRNA. It still must be validated across this population, but I'm sure the presenter will say more now in his presentation.
Hello everyone, I'm Augustin Krab, a medical student from Belgium studying in Romania. The project started when we were all in first year and we decided to see if early cardiac testing could become more accessible, faster, and more useful for the patients everywhere. In acute myocardial infarction, the first hours are critical. If the diagnosis is made early, treatment can dramatically change the patient's outcome. But in those first golden hours, the traditional biomarkers may still be negative or not sufficiently elevated. That creates a dangerous diagnostic gap. So together we decided to investigate whether microRNAs could help bridge that gap as early biomarkers of cardiac distress. To explain our methodology, here is Andrea.
Thank you, Augustine. Hi, my name is Andrea and I'm studying medicine in Romania. We conducted a systematic review and meta-analysis on the diagnostic potential of circulating microRNAs in acute myocardial infarction. In total, we analyzed 41 studies involving more than 1,100 patients, with 14 studies included in the meta-analysis. The results were promising. Many microRNAs showed statistically significant diagnostic potential. However, the evidence was far from perfect. We also found major heterogeneity between studies and a high risk of bias, which means that although the concept is strong, the current research is not yet ready for clinical use.
Exactly. Hi, I'm Leah. I'm a student in Netherlands. One of the biggest problems we found was the lack of standardization. Different studies use different microRNAs, different sample type, different extraction methods, and different diagnostic thresholds. In other words, the field is often comparing apples to pears. This makes it difficult to transfer promising research into reliable clinical tests. And for a biomarker to truly help patients, especially in emergency settings, it needs to be not only accurate, but also reproducible, standardized, and accessible.
Thank you, Leah. Hi, I'm Serena and I'm studying medicine in Italy. For us, this project was also about collaboration. As for students studying in different countries, we brought together different skills, perspectives, and ideas on how to develop this work. Our shared goal was not only to analyze the literature, but also to understand what's missing and how this field could move forward. We believe that microRNA has the potential to become a smarter, earlier, and more accessible diagnostic strategy for myocardial infarction.
Okay. Then there is the winner for this year. It is a collaborative studies between India and Nepal, in particular from Himalaya Medical College, Vilar and Maraguni Medical Campus, Kathmandu. This was the leading institution. This first prize winning analyzes widespread public health concern of self-medication in India and Nepal, detailing socioeconomic factors deriving the practice, its severe clinical consequences such as antimicrobial resistance, and proposing solutions such as stricter drug regulations and community education. But now the authors, I'm sure, will present it more clearly.
A tablet can ease a pain, but it cannot replace a diagnosis. Good day, respected organizers and participants. Self-medication is a growing public health concern. In our study context, nearly 70 to 78% of people in India and Nepal, representatives of many developing countries, practice self-medication, often without direct medical supervision. This behavior is driven by high healthcare costs, limited access to medical facilities, and easy availability of over-the-counter medicines. In addition, many individuals rely on past prescriptions, internet advice, or informal sources, which further increases the risk. But the real concern lies in the consequences. Self-medication can lead to wrong drug use, adverse drug reaction, delayed treatment, and misdiagnosis. Most importantly, the misuse of antibiotics contributes to antimicrobial resistance, making infection increasingly difficult to treat. And this brings us to the key insight: awareness alone is not enough. Even though people understand the risk, socioeconomic condition, healthcare access, and cultural practices continues to influence their decision. So solution must go beyond awareness. We need community education, stronger drug regulation, and an active role of pharmacists in guiding the rational use of medicine. In the end, self-medication is not just individual habit. It reflects larger system-driven issue, because in many communities there may be a pharmacy every 3 kilometers, but not a healthcare center in 10. That's why treating yourself never should cost your health. Thank you.
Okay, thank you. And so we move on to the conclusions.
Thank you. Thank you, Professor Gabriel Stocco, for this nice presentation of the winner poster. And as you said, it's the first time that this category of poster, international collaboration, has been issued, and we are very pleased to see we have participants. So maybe next year we will have many more. And now we just move on to our final section, the conclusions that will be delivered by Professor Scott Wallman from the Department of Pharmacology, Physiology, and Cancer Biology, Philadelphia, United States. He's a counselor on the Medical and Clinical Pharmacology Committee, IUPHAR. Thank you very much. Go.
Thank you. I want to thank Maribel and Priya for chairing what has been a truly global meeting, the 2026 World Smart Medication Day, focused on race, ethnic, and socioeconomic influences on clinical pharmacology. We've had more than 120 participants today globally around the world, which is fantastic. I want to thank the faculty for their presentations, the poster submitters for submitting wonderful posters, and the award winners for the posters that we've heard about. I'd like to remind everybody, or at least announce, the 2027, I think it's on the next slide, the 2027 IUPHAR World Smart Medication Day. The title, Clinically Relevant Drug Interactions, May 6th, 2027. Let's save the date for that. And then the next slide. This is a reminder for the World Congress of Basic and Clinical Pharmacology 2026, July 12th through 17th in Melbourne, Australia. And we hope to see all of you at that meeting. So again, thanks to all the participants globally around the world. It was a great meeting, and we look forward to seeing you in Melbourne and again next year at this time for the 2027 World Smart Medication Day. I'm going to bring this meeting to a conclusion. Thanks for your participation.
Thank you. Thank you.
Thank you.